We can start.
No, sir, just 1 second. Yes, sir. We can start.
Jyotsna, please proceed.
Good morning, everyone. Today we'll be talking about approach to management of major electrolyte disorders in ICU. And today we'll be going through hyponatremia and hypernatremia. My overview would be physiology, hyponatremia definitions, approach, types of hyponatremia, management, osmotic demyelination syndrome, and hypernatremia. Total body water has two compartments, extracellular fluid and intracellular fluid. Extracellular fluid comprises of 1/3 of this, and intracellular fluid, the remaining 2/3. Sodium is principal cation in ECF and potassium in intracellular fluid. Serum sodium concentration does not depend on total body sodium, but it is determined by the ratio of total body solutes to total body water. Main function of sodium is related to blood volume status, water balance and cell membrane potential, acid-base balance, and nerve conduction. Hyponatremia represents an imbalance between the ratio of total body solutes to total body water, where total body water is more than total solutes. Coming to definitions of hyponatremia. Hyponatremia is defined when serum sodium is less than 135 milliequivalents, and it is significant when the concentration of serum sodium is less than 125. It is severe hyponatremia when sodium levels are less than 120 milliequivalents. If hyponatremia has developed over a period of less than 48 hours, it is called acute hyponatremia. And if hyponatremia has been present for more than 48 hours or duration is not clear, then it is labeled as chronic hyponatremia. In an attempt to restore volume, brain reduces the number of osmotically active particles by extruding them into extracellular space over 24 to 48 hours. Hence the time frame for acute and chronic hyponatremia. In acute hyponatremia, the onset is rapid. There is rapid osmotic influx of water into brain to equalize the osmolar gradient. So there is risk of cerebral edema and potential severe symptoms. But in chronic hyponatremia, the onset is gradual and there is time for cerebral adaptation of movement of osmolytes and water. The symptoms may be mild, or in some patients it may be asymptomatic. History and physical examination is important to assess the severity of hyponatremia and urgency of correction. Hyponatremia leads to decrease in osmolarity, which causes movement of water into cells. This may lead to cerebral edema and depicts as neurological dysfunction. We have to examine previous records of serum sodium to assess the chronicity. In chronic hyponatremia, due to cerebral adoption, neurological symptoms are much less severe. Increase in vasopressin levels is pathognomic feature of all types of hyponatremia. Old age is a strong risk factor for hyponatremia, particularly in hospitalized patients. Aging and frailty reduce the capacity to maintain homeostasis in response to environmental, disease-related, and iatrogenic disturbances in water balance. Mechanisms may include impaired thirst sensation, reduced total body water, reduced GFR, loss of urinary concentration capacity, and decreased renal responsiveness to AVP in the elderly. Age-associated reduction in kidney function may occur because of loss of parenchymal mass, tubulopathy, interstitial fibrosis, glomerulosclerosis, and microscopic arteriolar shunts. Coming to history, we'll have to look into fluid losses, which give us like vomitings, diarrhea, and diuretic use. We have to look into the history of excess water intake, low protein intake, use of any medications like thiazides, thiazide type diuretics, mannitol, desmopressin, and IVIG. We'll also have to take history of malignancy, HIV, hepatic failure, and renal failure, and any previous history of hyponatremia. We have to look into the signs of extracellular volume depletion like decreased skin turgor, low JVP, persistent hypotension. We'll also have to look into signs of features of fluid overload, which may be represented as pedal edema, ascites, and pleural effusion, which can be due to heart failure, cirrhosis, or renal failure. Signs of adrenal deficiency or hypothyroidism should also be looked into. Coming to symptoms, in acute hyponatremia, there could be headache, lethargy, obtundation, disorientation, drowsiness, impaired consciousness, and seizures. Sometimes patient may have vague symptoms like anorexia, nausea, and lack of balance. In chronic hyponatremia, few patients may be asymptomatic even if serum sodium is less than 120 milliequivalents per liter. In few patients, there may be nausea, fatigue, dizziness, gait disturbances, forgetfulness, confusion, falls, and fractures. Coming to approach, we'll have to assess volume status, measure serum and urine osmolarity, and measure spot urine sodium. Serum osmolality should always be measured rather than calculated. Whenever hyperglycemia is present, correct serum sodium concentration for the effect of glucose to identify correct sodium level and exclude hypertonic hyponatremia. Sodium concentration will decrease by 1.4 milliequivalents per liter for each 100 milligram per ml increase in glucose concentration. Coming to diagnostic approach, once we know that patient serum sodium is less than 135 milliequivalents per liter, we should look into the symptoms. Is the patient symptomatic or asymptomatic? If the patient is symptomatic, we'll go ahead with the treatment. If the patient is asymptomatic or has mild symptoms like headache, lethargy, and dizziness, we have to determine the serum osmolality. So we can divide here like hyponatremia with normal serum osmolality, hyponatremia with low serum osmolality, and hyponatremia with high serum osmolality. Coming to normal serum osmolality, it is also called as pseudo-hyponatremia or isotonic hyponatremia. Two major things which fit into this are hyperlipidemia and paraproteinemias. Coming to high osmolality hyponatremic conditions, it is also called as hypertonic hyponatremia. Major conditions are hyperglycemia and administration of mannitol or sorbitol. Coming to hyponatremia with low serum osmolality, we'll have to assess the volume status. Is the patient hypovolemic, euvolemic, or hypervolemic? In hypovolemia, we should again check for urinary sodium. Is it greater than 20 milliequivalents or less than 20 milliequivalents? If it is greater than 20 milliequivalents, that means there is renal loss. Example, diuretics or mineralocorticoid deficiency. If urinary sodium is less than 20 milliequivalents per liter, it is because of the extrarenal losses. Example, vomitings, diarrhea, pancreatitis, where there is third spacing or bowel obstruction. If the patient has hypervolemia, that is increased total body water, and urine sodium is less than 20 milliequivalents per liter, this is because of heart failure, cirrhosis, and hypoalbuminemia. If urine sodium is greater than 20 milliequivalents per liter, this is renal failure. Coming to euvolemic status, if the patient has euvolemic status, usually urinary sodium is greater than 20 milliequivalents per liter. Then we go for checking the urinary osmolality. Is the urinary osmolality greater than 100, less than 100, or the osmolality is variable? If urine osmolality is greater than 100, common conditions are syndrome of inappropriate antidiuretic hormone, hypothyroidism, and adrenal insufficiency. Urine osmolality, if it is less than 100, it is usually due to primary polydipsia and low solute intake, example, beer protomania syndrome. If the urine osmolality is variable, it is reset osmostat, which we see in elderly age group. Other investigations, we have to get it done to ascertain the cause and severity of hyponatremia. Serum potassium chloride, ABG help us, and other investigations like glucose, urea, creatinine, total proteins, triglycerides, uric acid, serum TSH, cortisol should also be sent. Coming to types of hyponatremia, there are broadly three types here: hypoosmolar, hyperosmolar, and isoosmolar. In hypoosmolar, we have euvolemic, we have hypervolemic, and we have hypovolemic. In euvolemia, we have SIADH, hypothyroid, adrenal insufficiency, and psychogenic polydipsia. In hypervolemia, we have cirrhosis with hyponatremia, and in hypovolemia, we have drug-induced hyponatremia and cerebral salt wasting. We'll go through each of these in brief. Coming to syndrome of inappropriate antidiuresis or syndrome of inappropriate antidiuretic hormone secretion, this is the most common cause of hyponatremia in euvolemic patients with a high urine osmolarity and low serum osmolality. The diagnostic criteria for this is patients are usually euvolemic, there is low serum osmolality, urine osmolality is high, that is greater than 100, and there is elevated urinary sodium excretion greater than 30 millimoles with normal salt and water intake. There should be absence of other potential causes of euvolemic hypoosmolality like glucocorticoid insufficiency or severe hypothyroidism, and normal renal function should be there, and there should be absence of diuretic use. When we come to causes of SIADH, it could be caused by malignancies, solid organ malignancies, particularly lung, nasopharynx, and lymphomas. Coming to pulmonary disorders, any chronic infections, cystic fibrosis, respiratory failure may also cause SIADH. Coming to CNS disorders, infection, hemorrhage, trauma, thrombosis, tumor, hydrocephalus, any autoimmune condition may also cause SIADH. In transient non-osmotic stimuli, we have nausea, pain, stress, prolonged endurance, exercise, general anesthesia, and pituitary surgery can lead to SIADH. In idiopathic cause, we have the reset osmostat, and in hereditary, this could be because of activating mutation of V2 receptor, which may lead to nephrogenic SIAD. Coming to phenotypes in SIAD, initially there were 4 phenotypes that were isolated, and now 5th phenotype has been added to it. Type A, Type B, Type C, Type D, and Type E. In Type A, there is persistently raised arginine vasopressin regardless of increase in serum osmolality. We can see this in pituitary or paraneoplastic source. In type B, there is low osmotic threshold for AVP secretion seen in reset osmostat, that is in old age. Type C is a rare pattern where there is abnormal AVP response only at low osmolality. This is due to dysfunction of inhibitory neurons in hypothalamus. Type D, AVP is undetectable because of unidentified antidiuretic substance from tumor cells or gain of function mutation in V2 receptor, that is nephrogenic SIAD. Type E, there is linear decrease in copeptin concentration with increasing serum osmolality, which represents reset barostat or resolution of acute type A SIAD. Coming to management of SIAD, the first line of management is fluid restriction, that is less than 1000 ml per day. If serum sodium does not improve at target rate, fluid restriction can be reduced to 750 ml or 500 ml per day with caution. If this is if serum sodium levels are refractory to fluid restriction, that is sodium not improving by at least 2 millimole per liter per day, then second line of drugs are started. They are tolvaptan, urea, SGLT2 inhibitors, and others like sodium chloride tablets. Tolvaptan, the starting dose is 7.5 mg, and here we have to allow free fluid intake. That is, there is no fluid restriction, but we have to monitor for overcorrection. When we start giving urea, the starting dose is 30 grams daily, and it has to be combined with orange juice for improving the taste. And fluid restriction has to be continued. Coming to SGLT2 inhibitors like dapagliflozin or empagliflozin is given as 25 mg daily with or without fluid restriction. Sodium chloride tablets with or without loop diuretics can be given, but the evidence is very much limited here. After starting second line of therapy, we have to see if sodium levels are improving at a target levels, at our target. If it is improving too fast, then we have to start reversal or mitigation therapy, that is cease the active treatment, start giving IV hypotonic fluid and start desmopressin. If it is improving at the rate of our target, we have to continue sodium normalization. If the improvement is too slow or there is decrease in sodium concentration, we have to modify the dose or reassess the underlying diagnosis and try an alternate second line therapy. Coming to second line of drugs and their mechanism of action, tolvaptan is a V2 receptor antagonist. This decreases water reabsorption, increases the urine output, and correction of dilutional hyponatremia. Coming to urea, urea increases the plasma osmolality, creates osmotic gradient, and promotes excretion of excess water by kidneys. It increases the sodium levels by reducing the water retention. Coming to SGLT2 inhibitors, they work by inhibiting sodium glucose transporter 2 in renal proximal tubules. This reduces glucose reabsorption and promotes osmotic diuresis. This is just a pictorial representation of whatever we have spoken. If it is acute, we go for management. If it is chronic SIAD, fluid restriction, second line of therapy, and look into our targets. Coming to adrenal and thyroid function. Adrenal insufficiency is important and treatable cause of hyponatremia that can mimic SIAD. Patients with clinical suspicion of insufficiency should get empirical glucocorticoid treatment immediately, even before waiting for the lab values. But random cortisol and ACTH should be drawn before administration of glucocorticoid. Both primary and secondary adrenal insufficiency can cause hyponatremia. In primary adrenal insufficiency, there is renal salt wasting due to mineralocorticoid deficiency. The gold standard investigation for primary adrenal insufficiency is ACTH 124 stimulation test, which is also called a short synaptin test or cosyntropin stimulation test. In this, we administer 250 micrograms of cosyntropin parenterally, and cortisol levels are measured after 30 to 60 minutes. A peak cortisol concentration less than lab cutoff indicates primary adrenal insufficiency. In patients with hemodynamic instability, hydrocortisone should be given 100 mg stat followed by 50 milligrams 6th hourly. Water diuresis after glucocorticoid therapy is supportive of adrenaline insufficiency as underlying cause of hyponatremia. Hyponatremia in profound hypothyroidism may be due to myxedema, cardiac failure, and systemic hypotension. Coming to hypervolemic hypoosmolar hyponatremia, we see this in patients with cirrhosis, nephrotic syndrome, cardiac failure, and renal failure. Patients with hyponatremia due to cardiac failure or cirrhosis have advanced disease and clinically apparent peripheral edema or ascites with previous diagnosis. There is no evidence that correction of hyponatremia improves the hemodynamic abnormalities associated with severe underlying chronic disease. The indications to correct hyponatremia are serum sodium less than 120 milliequivalents per liter with or and presence of symptoms that might be due to hyponatremia. In hyponatremia due to cardiac failure, there should be we should do fluid restriction. Loop diuretics may be added, and along with loop diuretics, angiotensin inhibition with AC inhibitors or angiotensin 2 receptor blockers can be added. Tolvaptan may be added when other management options have failed to increase sodium levels above 120 milliequivalents and ameliorates the symptoms of hyponatremia. We have to treat the underlying disease and avoid extra sodium. In hyponatremia due to cirrhosis, we have to withdraw beta blockers, alpha blockers, and diuretics, particularly thiazide diuretics. We have to correct hypokalemia and treat the patients who have persistent hypotension. Midodrine is the agent typically used to increase blood pressure in cirrhotic patients. Severe symptomatic patients, infusion of albumin or hypertonic saline should be considered, and hemodialysis in advanced renal dysfunctions. Coming to hypovolemic hypoosmolar hyponatremia, we have to consider volume depleted states. It could be renal or extra-renal. Management is by volume replacement and treating the underlying cause. When we have this hypovolemia, we look into urinary sodium, low urinary sodium or high urinary sodium. If the urinary sodium is high, we look into urinary chloride also. So in the conditions with low urinary sodium are GI fluid losses like diarrhea and pancreatitis. Conditions having high urine sodium, that is greater than 40 milliequivalents, with low urinary chloride are metabolic alkalosis caused by vomitings and due to contraction alkalosis in volume depletion and loss of bicarbonate in urine. High urinary sodium greater than 40 milliequivalents with high urinary chloride, patients with renal salt losses. Coming to cerebral salt wasting, it is usually a rare cause that occurs in setting of hyponatremia after a cerebral insult, that is traumatic brain injury, subarachnoid hemorrhage, a tumor, or stroke. There is release of natriuretic peptide or reduced sympathetic stimulation to kidneys, which leads to inhibition of sodium resorption and suppression of RAS system, which causes renal salt wasting and water loss. BNP is raised and fractional excretion of sodium remains elevated even after the correction of serum sodium. A novel natriuretic protein, haptoglobin-related protein without signal peptide, has been proposed as alternative marker but has not been validated yet. Management of cerebral salt wasting is treating the underlying cause, volume replacement to match the urine losses, and the amount of sodium required is sodium deficit into total body water. Coming to drugs causing hyponatremia, the drugs that release like AVP release stimulants or potentiators lead to hyponatremia. They are antidepressants like SSRIs and tricyclic antidepressants and MAO inhibitors. In anti-epileptics, carbamazepine, oxycarbamazepine, sodium valproate, lamotrigine all can lead to hyponatremia. Antipsychotics and cancer therapy drugs where vinca alkaloids, alkylating agents, and methotrexate can also lead to hyponatremia. In miscellaneous agent, we have tramadol and NSAIDs, proton pump inhibitors, nicotine, and monoclonal antibodies also, which lead to hyponatremia. The other drugs that may lead to hyponatremia are AVP receptor activation, drugs which lead to AVP receptor activation, like AVP analogs, that is desmopressin, vasopressin, and terlipressin, and the drugs that have receptor crosstalk like oxytocin. Recent osmostat is seen in carbamazepine and venlafaxine. Natriuretic agents that may mimic SIAD are thiazides, indapamide, loop diuretics, platinum compounds. Coming to hypertonic hyponatremia, this is also called as translocational hyponatremia. There are increased effective osmolytes like glucose and mannitol. They affect both the direct and indirect measurement of sodium. Excess of osmotic active solutes in plasma draws water from intracellular compartment to extracellular compartment, reducing sodium levels. Agents other than glucose are mannitol, glycine, histidine, tryptophan, ketoglutarate combination that is used during cardiac surgery or organ transplants. Patients with recent prostate or uterine surgery may also have hyponatremia because of absorption of irrigating solutions like glycine, sorbitol, or mannitol. Treatment is to stop infusion of irrigating solution. If there is hyperglycemia, stop or decrease glucose administration, give insulin and fluids, and target a drop in glucose concentration of 75 to 100 milligram per deciliter per hour. Coming to isoosmolar hyponatremia, this is also called as pseudohyponatremia. This is because of increased solutes in blood like proteins and lipids. Increase in 1 gram of total protein. For every increase in 1 gram of total protein, there is decrease in sodium by 0.5 to 1 milliequivalent per liter. And for every increase in 1000 milligram per deciliter of triglycerides, there is decrease in sodium by 1 to 2 milliequivalents per liter. They can be endogenous or exogenous. Endogenous is hypertriglyceridemia, monoclonal gammopathy, and obstructive jaundice. Exogenous is following administration of IVIG. There is a laboratory artifact on indirect measurement that falsely lowers the sodium concentration. Direct measurement is not affected and gives us the accurate sodium value, which may be normal. Coming to goals of treatment. Goals of treatment of hyponatremia is to prevent further decrease in sodium concentration, to decrease ICP in patients at risk of developing herniation, to alleviate the symptoms of hyponatremia, and to avoid excessive correction of hyponatremia. Sodium deficit is calculated by total body water into desired sodium minus measured sodium. Increase in serum sodium by any fluid is calculated by infusate sodium minus serum sodium by total body water plus 1. For hypertonic saline, infusion rate is weight into desired rate of correction. For isotonic saline, it corrects at 1 to 2 milliequivalents per liter for every 1 liter. Raise of sodium should always be verified by repeated sodium measurement. These are few formulae which help us in correction of hyponatremia. Treatment always must be individualized, and we have to consider severity, duration, and symptoms. The risk of complications is greater in acute hyponatremia and needs aggressive therapy. In chronic hyponatremia has greater risk of complications from over-aggressive therapy and needs close monitoring to avoid overcorrection. Coming to the guidelines for management, we have the United States guidelines and European guidelines. For acute symptomatic hyponatremia, according to US guidelines, we give 3% NaCl bolus, 100 ml over 10 minutes, and it can be repeated thrice. In European guidelines, we give 3% NaCl, 150 ml over 20 minutes, and this also can be given 2 to 3 times. If patient has moderate symptoms, according to US guidelines, continuous infusion of 3% NaCl given at a rate of 0.5 to 2 ml per kg per hour. In European guidelines, we give bolus 3% NaCl 150 ml over 20 minutes, and that is given only once. For chronic hyponatremia in SIADH, according to US guidelines, the first line is fluid restriction, second line is demyclocycline, urea, or Vaptans. According to European guidelines, the first line is same like fluid restriction, second line is urea or loop diuretics along with oral sodium chloride. They do not recommend, or they recommend against using Vaptans. They also recommend against lithium or demyclocycline. In hypovolemic hyponatremia, isotonic saline is given according to both the guidelines. In hypervolemia, fluid restriction is given in both the guidelines, but Vaptans are considered in United States guidelines, and in European guidelines, they recommend against using Vaptans. Coming to correction rates, in US guidelines, the minimum is 4 to 8 millimole per day, and the limits are 10 to 12 millimole per day. In European guidelines, the limit is 10 millimoles per day. Coming to management of overcorrection, we have to see that baseline greater than 120 millimole per liter, then it is probably unnecessary. if baseline serum sodium is less than 120, we have to start relowering measure with electrolyte free water or desmopressin after correction exceeds 6 to 8 millimole per liter per day. Coming to osmotic demyelination syndrome, this is caused by rapid correction of hyponatremia. Here, serum CSF tonicity increases faster than brain intracellular tonicity. This leads to osmotic shift of water out of brain cells. There may be neuronal dehydration, which leads to cellular crenation, that is shrinkage and deformity of cells, and there is also disruption of blood-brain barrier. This leads to oligodendrocyte damage and demyelination of neurons. There is aggregation of proteins, DNA fragmentation, and apoptosis, which leads to myelin damage. The risk factors for development of osmotic demyelination syndrome in chronic hyponatremia are if the patient has extremely low serum sodium concentration, that is less than 105 millimoles, or if the symptoms are very severe, like decreased conscious state or there are vomitings, in patients with hypokalemia, alcohol abuse, malnutrition, advanced liver disease, and patients with hypotonic urea. Osmotic demyelination syndrome may also occur as a result of overcorrection, that is due to iatrogenic or spontaneous. Iatrogenic is mainly due to excessive administration of hypertonic saline. Higher risk clinical scenarios for overcorrection include reversible causes of hyponatremia, glucocorticoid replacement in adrenal failure, and the main one is provision of solute in patients with malnutrition and low solute intake. Example in alcohol abuse, that is beer protomania, or poor diet in older individuals, what we call as tea and toast diet. The signs and symptoms of osmotic demyelination syndrome are dysarthria, dysphagia, flaccid quadriparesis initially, and later which may turn into spastic, horizontal gaze paralysis, locked-in syndrome, and coma. Myelin damage is most apparent in pons, but extrapontine myelination can affect basal ganglion and thalamus. The clinical features associated with extrapontine myelinolysis are tremors, ataxia, Parkinsonism, dystonia, and catatonia. The same thing which we have already seen, the correction targets in US guidelines, it is 4 to 8. European guidelines, it is target is 5 and limit is less than 10 millimoles. But the other thing which is added here is hyponatremia with risk factors for osmotic demyelination syndrome. We keep a little less target in US guidelines, and in European guidelines, the general hyponatremia guidelines are same as hyponatremia with risk factors for osmotic demyelination syndrome. Coming to management, there are no established therapies for treatment of osmotic demyelination, but the tried therapies are glucocorticoids. They reduce histological damage. Plasmapheresis removes myelotoxins and restores organic osmolytes. Intravenous immunoglobulin, zolpidem, administration of osmolytes like urea, myoinositol, which protect against myelinolysis, and supportive measures like intubation, ventilation, and if patient is surviving, they may need neurorehabilitation for a longer period. Coming to hypernatremia. Hypernatremia is characterized by rise in serum sodium above 145 milliequivalents. Normal serum osmolarity of 280 to 295 milliosmoles is maintained by vasopressin, thirst, and renal response to vasopressin. Hypernatremia is caused by dysfunction of these mechanisms. Hyperosmolar condition caused by a decrease in total body water is relative to the sodium content. The goal of management involves identification of hypernatremia and correction of volume disturbances and hypertonicity. Coming to classification of hypernatremia, it can be related to absolute serum sodium concentration. We can classify as mild, moderate, severe, and extreme. In mild, 146 to 150, moderate is 151 to 155. It is labeled as severe when concentrations are greater than 150, and extreme when concentrations are greater than 190 millimoles per liter. The criteria, if we take it as a time of development, it is like acute versus chronic, and clinical assessment of volume status, it is hypovolemic, euvolemic, and hypervolemic. History and physical examination is important to assess the etiology of hypernatremia and severity of the problem. We have to look into extrarenal fluid losses, example burns, vomiting, diarrhea, fever, and high minute ventilation in patients with who are mechanically ventilated. We have to look if there is any decreased fluid intake or polyuria. We have to review the drug chart, like drugs causing diabetes insipidus, osmotic diuresis, osmotic laxatives. We have to review previous sodium levels to assess the chronicity. And we have to look if there is any hypertonic solute infusion like hypertonic saline or sodium bicarbonate. And hypertonic feed also should be taken care if we are giving any high protein formula or concentrated formulas. Coming to signs and symptoms of hypernatremia, they depend on characteristics of hypernatremia. If there is any cognitive dysfunction and symptoms associated with neural cell shrinkage, patients may have symptoms like lethargy, confusion, irritability, seizures, myoclonic jerks, and focal neurological deficit. If there is dehydration or clinical signs of volume depletion, patients may have tachycardia, oliguria, abnormal skin turgor, dry axilla, and intense thirst. The other clinical findings could be weight loss, generalized weakness, fever, and labored respiration. In patients with extreme hypernatremia with neurological deficits, an initial CT scan has to be recommended to detect possible intracranial hemorrhage due to vascular rupture from shrinkage of brain cells. Other rare neurological deficit is transient ventriculomegaly. Age and levels of serum sodium are age and the levels of serum sodium are independent risk factors for mortality in hypernatremia. In geriatric age group, there can be impaired thirst mechanism, renal concentrating ability to increase sodium excretion in response to sodium load is impaired. There is decrease in total body water predisposing to dehydration and subsequent hypernatremia with minimal loss of fluid. Coming to etiology of hypernatremia, is it because of hypovolemia, hypervolemia, or euvolemia? If it is hypovolemia, already we have looked into this, like are there any extrarenal losses, burns, osmotic diuretics? We have to look into all this. If there is hypervolemia, this could be because of hypertonic saline, bicarbonate infusion, or accidental salt ingestion. If patient has euvolemia, it could be because of increased insensible losses or hyperventilation, and mostly free water loss is from intracellular fluid and interstitial spaces. Coming to other investigation, we'll have to send arterial blood gases, serum electrolytes, glucose, urea, creatinine, uric acid, hematocrit, serum osmolality, urine osmolality, and sometimes imaging like CT scan or MRI will be beneficial. Coming to approach, once the diagnosis of hypernatremia is considered, then we have to try to determine the etiology. If etiology is clear, we will understand we will understand the reason for hypernatremia. But if etiology is unclear, check for urine osmolality. If urine osmolality is greater than 600, or is it less than 600? If it is greater than 600, this implies that there is extrarenal mechanism. Again, here also we can have hypovolemia, euvolemia, and hypervolemia. So we'll have to see if the patient is fitting into any of these categories. Hypovolemia, there could be because of GI losses and skin losses. Euvolemia could be because of impaired thirst mechanism or lack of access to water because of immobility or any intubated patient. In hypervolemia, it could be iatrogenic or ingestion. Example, salt water injection, salt water emetics, or soya sauce. If urine osmolality is less than 600, again we'll have to see if it is hypovolemic, euvolemic, or hypervolemic. Hypovolemia, it is diuretics or osmotic diuresis. Euvolemia is because of diabetic insipidus, and hypervolemia could be because of Conn syndrome or Cushing syndrome. Coming to management, aim for symptom resolution, 10 to 15% improvement in sodium levels in first 24 hours. The correction in chronic setting like total should be totally less than 10 to 12 milliequivalents per 24 hours. We'll have to calculate free water deficit. Free water deficit is total body water into measured sodium by 140 minus 1, or 4 ml into body weight into desired change in serum sodium in milliequivalents per liter. This can be given as 5% dextrose or free water by nasogastric tube or orally. Large volumes of 5% dextrose will lead to hyperglycemia, and if needed, insulin should be given to prevent glycosuria. Otherwise, osmolar diuresis can worsen hypernatremia. Repeat sodium levels and entire calculation every 12 hours and replan infusion rate. In general, a net positive balance of 3 ml of electrolyte free water per kg body weight will decrease serum sodium by 1 milliequivalent per liter. Initially, 5% dextrose at the rate of 3 to 5 ml per kg should be infused, which should be reduced to 1 ml per kg once serum sodium normalizes. Sodium and glucose measurement should be performed every 4 to 6 hours till serum sodium is 146 milliequivalents per liter. As per current evidence in treating hypernatremia, a reduction rate of no more than 0.5 millimoles per liter per hour or greater than 12 millimoles per liter in 24 hours is recommended. But rapid correction of hypernatremia with more than 0.5 millimole per hour or greater than 12 in 24 hours was not associated with high mortality or cerebral edema and decreased the length of stay. Rapid correction, which is increasing the rate of free water administration, is beneficial in patients developing hypernatremia secondary to dehydration. The goal of treatment for hypernatremia is restoration of plasma tonicity and rapid correction. This improves the prognosis by preventing the effects of cellular dehydration. Coming to management, hypernatremia, first we have to see if it is acute or chronic. If it is acute, rapid correction. If it is chronic, slow correction. In both the things, we have to look for volume status. Is it hypovolemia, euvolemia, or hypervolemia? In hypovolemia, we correct volume deficit first and then the water deficit. Volume deficit is by initial fluid resuscitation with balanced crystalloids until hypovolemia is improved, and treatment of underlying cause of losses. Then correction of water deficit by calculating the water deficit and administering 0.45% saline or 5% dextrose or oral rehydration. If the patient has euvolemia, we have to correct water deficit. Calculate the water deficit, administer 0.45% of saline, 5% dextrose. In central diabetes insipidus with severe losses, there may be a need of desmopressin. In long-term therapy is needed for nephrogenic and central diabetes insipidus. If the patient has hypervolemia, we have to target removal of sodium, by discontinuing the offending agents, free water replacement, and hemodialysis if needed for renal failure. The most serious complication of hypernatremia is subarachnoid or subdural hemorrhage. This is due to rupture of bridging veins and dural sinus thrombosis. This can lead to permanent brain damage or death. The conclusion is that hyponatremia results in cellular swelling and water shifts into cell following high solute concentration. In hypernatremia, there is cell shrinkage and water shifts out of the cell following higher solute concentration. Thank you.
Shyam?
Hello. Hello.
Yeah, Ghanshyam.
Hello. Hello.
Shyam, we can hear you.
Hello. Can you hear me, Steven?
Hello, Shyam?
Hello.
Yeah, we can hear you.
Just a couple of points. one, see, many a times establishing
We have lost you. Can't hear you, Ghanshyam.
hello.
We can't hear you.
I just
We can't
Hello?
hear you. We can't hear you,
hello.
Ghanshyam.
Is it, can you hear you now? Can you hear me now?
Yeah, you have to start from
Hello?
the beginning. Nothing
Okay.
was heard.
Yeah. Okay. So just a couple of points. One, many a times in intensive care, it's very difficult to establish the exact reason why the patient is hyponatremic, and you may not be knowing the reason why, or establishing the diagnosis or the exact reason may be a little difficult. Second thing is, many a times, probably a therapeutic challenge uh, may be sufficient enough where you correct the sodium levels, and retrospectively, probably you'll get the diagnosis as to what could have been the possible reason. Third thing, never employ more than one technique of correcting hyponatremia. There is a tendency of overcorrection. Fourth, you would very commonly see that hyponatremia is something which patients come to us with, or many of the patients get admitted to hyponatremia, but hypernatremia is usually an iatrogenic problem. We'll find a good number of patients who come to the ICU with normal sodium or lower sodium, eventually ending up with hypernatremia. So just be very careful about the different medications that we give, as a good number of these medications have a very high sodium load. One of the commonest reasons for hypernatremia is inadequate feed dilutions. So patients who are enteral nutrition, when their feed volumes are inappropriately diluted or not adequately diluted, you can actually iatrogenically cause hypernatremia in these patients. Thank you, Srinivas. Those are a couple of things that I just thought of adding.
So sodium imbalance, I think, it is like the malaria of electrolyte disturbance. Everybody thinks they are the experts, but it is the most mismanaged or misunderstood, misinterpreted set of electrolyte imbalances, and it's the reason why a lot of complications happen to these patients. Most of the things I think Ghanshyam has already covered, but iatrogenic causes, as Ghanshyam said, are causes of both hyponatremia and and we always believe that if a patient develops osmotic demyelination, it is because of over or under correction or rapid correction. It's not always true. The simple existence of a hyponatremia or hypernatremia can produce osmotic demyelination irrespective of the rapidity of the correction. It is also to be understood that it is not only hyponatremia and its correction which can cause osmotic demyelination. Hypernatremia and its correction can also produce osmotic demyelination. Among the iatrogenic causes,
Srinivas, we lost you.
some things that are commonly overlooked of in the elderly patients, it is the osmotic laxatives like lactulose which are prescribed and forgotten, which end up causing a lot of havoc with hypernatremia. When you prescribe antibiotics, always make sure you read the composition, because most of these antibiotics are sodium salts because of the ease with which it can actually penetrate the cellular membrane. So that itself is some of these antibiotics, especially ticarcillin, clavulanic acid, colistin, they are heavily sodium, they carry a very heavy sodium load. So all these aspects add to the sodium load and the sodium imbalance in the patients. And unlike our understanding about the ECG abnormalities of hyperkalemia and hypokalemia, so sodium also has an effect on the QT interval. So these are additional points I needed to add, but it was a very exhaustive, but at the same time to the point, practical description of these two common electrolyte abnormalities. Thank you all for joining us today. If you have any queries or comments, please do post them on the group from where you got the link from, and we will answer them at the earliest point of time. Thank you all for joining us. Please do subscribe to the Higgs channel and join us again next week for another session on critical care prescription. Thank you very much. Have a good day. Bye-bye.
Thank you, Jyotsna. Thank you, Srinivas.
Thank you, sir.